trying to support and help people with more complex presentations of what in the olden days was known only as post-traumatic stress disorder, but through Marilyn and others' pioneering work, I think a lot of people that we now use such techniques with, if we are going to use a diagnostic paradigm, would meet the criteria for something called complex post-traumatic stress disorder. And Marilyn was one of the members of the World Health Organization's ICD-11 working group on trauma spectrum disorders, which actually led to the inclusion of complex post-traumatic stress disorder as a diagnostic entity. If you want to know more about Marilyn, then please do Google Marilyn. She's had a fascinating career and has, published so widely and so well, and a lot of her papers are very, very worthwhile reading. So without further ado, I'm going to hand over to Marilyn, who's going to give us a talk for roughly about an hour on understanding and treating dissociation, and then we'll have time after that for some questions. And just to reassure everyone that the plan is to end as programmed at 16:45 today. So Marilyn, over to your good self. Thank you very much for joining us.
Thank you for that very kind introduction. And I want to say that in preparing for this talk, I felt like the more I studied dissociation, the less I really come to know about it. And maybe other people have that same experience. But I'll share with you today what I know, and I look forward to having a question and answer period where we can think more deeply about these issues. So the first question is, what is dissociation? And I like this definition. It's simple and clear and clinically relevant. Dissociation involves the absence of normal integration of psychological functions related to perception, memory, identity, and self of agency or will. Now, if you are like me and a practicing clinician, you've seen dissociation described or reported by your clients in many ways. And there's lots of different dimensions to the experience of dissociation. So sometimes people will say, time slowed down, form of derealization. Things around me seemed strange and unreal. I felt outside of my body. I saw the spotlight and froze, depersonalization. I can't remember what happened after I lost my job. I left the office and can't recall a thing after that. Amnesias or memory gaps. I looked at myself in the mirror and I didn't recognize myself. Identity disturbance. I felt like I was back in time. I curled up in a ball when he moved towards me, a re-experiencing symptom. And I heard my father's voice screaming, even though I knew he wasn't there. Sensory misperceptions. And I think all of these comments or experiences have in common a sense of disconnection and sometimes distortion with usual experience or perception. Okay, I have to try and go on to the next slide. So I'm actually very grateful to John Bruyere and E. Carlson, who have been studying dissociation for at least 25 to 30 years now. And between the two of them, I think they've done a really wonderful job in trying to characterize the types of dissociation or dimensions of dissociations that are commonly experienced. And I think at this point we can identify there are 5: depersonalization and derealization, gaps in memory and awareness, identity disturbances, cognitive behavioral re-experiencing, and sensory misperceptions. So overall, how can we characterize dissociation? It is a stress response associated particularly with exposure to traumatic events from which escape is difficult or impossible. It occurs at the time of exposure, namely peritraumatic, and later in situations which are direct or indirect reminders of the trauma as a, quote, learned response. It happens both in adulthood and childhood traumas, such as exposure to combat, sexual assaults, being a prisoner of war, and childhood abuse. I think very interestingly, there is a special relationship between childhood trauma or childhood adversity and risk for adult dissociation, which is very strong and convincing at this point. For example, Bonderlin and colleagues conducted a meta-analysis of 65 studies, including over 7,000 people, and found that dissociation is more common among those with childhood abuse, and that levels of dissociation are also higher among the same. An interesting study by Dan Stein for the World Health Organization across many countries and, of course, many people reported that childhood adverse events uniquely and controlling for many other types of events were associated with dissociation, and in particular, family violence, which would be a Criterion A event for DSM, and parental mental illness. And I think what these two things have in common from a child's perspective is experiences of threat or creation of fright. So these are the symptoms and the history of dissociation. How do we understand dissociation from a theoretical perspective that might help guide our interventions? And there are a few, probably about 4 different models, but I think that there are 2 that are particularly relevant to clinical work. The first is psychophysiological shutdown under inescapable circumstances, which has been really articulated well and developed by Steve Porges and Dan Shore. The idea here is that when resolution of threat via fight or flight is not possible, the, quote, strategy of last resort is physiological shutdown. And this is well known in the literature across humans and animals as a defensive action against threat that results in a rapid loss of energy and movement. So it's called flag or the death faint. And physiological shutdown involves severe disconnection from present awareness, including cognitive, emotional, behavioral aspects of functioning. So no movement, no awareness, and total shutdown emotionally. And when we see this in clients in treatment, variations of shutdown are expressed in emotional numbing, reduced cognitive processing, and maybe a mental haziness. There are some interventions for physiological shutdown that I think are really wonderful and directly go towards the nature of these particular symptoms. A set are body-based, where the effort is to re-engage the body with a message of safety. So, for example, one might involve a client in movement with intentional awareness, right? The mind and the body put together. So you might want to take a walk with your client or make a tea. There's a lot of movement involved. And the idea here is that the movement provides corrective information about the integrity of the body and agency in movement that counters old actions, old routines and beliefs, old action routines and beliefs. And I remember being very impressed once listening to David Clark talk about his work with a lorry driver who had gotten into an accident and had gotten pinned between his seat and the steering wheel, and he couldn't move. And they used, traditional exposure and review of the hot spots, particularly of his feeling pinned down. And there was no movement at all in his re-experiencing symptoms or in his SUDS ratings. David thought that perhaps they could move around the room while he was telling the story of his being pinned. And this really was a breakthrough, because as the client was telling about being pinned and unable to move, the physical movement, right, gave feedback about contradictory information, which is a lot of what, exposure is about. contradictory information that's absorbed and processed and updates the memory. So I think there are ways in which movement in a general way can provide corrective information. In the case that I just described, it was very specific to a particular memory, but I think we can do the same with clients who have generalized tonic immobility and loss of sense of agency in relationship to their body. There are behavioral interventions for physiological shutdown. You can, for example, help the client develop an exercise routine. I think this provides experiences of cycles of healthy arousal followed by calm. That activation and deactivation occur in cycles in a healthy and normal way, which again kind of creates a window of tolerance for these two different kinds of experiences, and one that is actually healthy and strengthening for the person. A cognitive intervention that's really lovely to use is guided imagery, where a person imagines a safe place and in particular focuses on the physical sensations of comfort and warmth. And lastly, just standard cognitive interventions of an enhanced self-concept, something like I can move flexibly between fight and flight and safety. Another very dominant theoretical frame that is specific to childhood trauma or childhood abuse is a developmental or attachment model. And there's a wonderful article by Bailey and Brandt from 2017, which gives a summary of this perspective. So the idea here is that under conditions of chronic abuse or neglect, the source of safety is also the source of danger. And this can be the parent, particular parent or caretaker, or it can be the home. So that, say, if there's violence in the home, if there's a person with a mental illness, that the child might not feel safe. And this opposing or contradictory circumstance for the child leads to several negative outcomes. One, of course, is dissociation, emotion regulation difficulties, and interpersonal problems. And the interpretation, the dynamic that occurs is that the child must engage with the abusive caregiver for survival purposes, and as a result, inhibits certain naturally occurring or desired urges to flee or avoid that source of danger, which would increase safety. And this kind of strained circumstance of approaching in a state where the urge is to flee results in dissociative behaviors that allow the approach. So that includes emotional numbing, reducing of attention, reducing of social engagement and processing, and sometimes even selective forgetting of what happened in the past that was hurtful in order to make the approach sustainable. In addition, there is the generation of a certain style or status of attachment, which is called fearful or disorganized. And disorganized attachment can be seen, say, in children, where they are reaching out with their arms, but say moving away with their feet or their body. That there is a style of interaction that vacillates between being both avoidant and clinging. The last aspect of developmental dissociation or trauma is really disruption in what we call the co-regulation, which is really the parent's responsibility to modulate the child's emotional experience, help soothe them when they're distressed, and help generate excitement at positive events. This really breaks down when the parent is abusive and the child is dissociating, and leads to emotion regulation deficits, rather immediately in childhood and long-term in adulthood. And in fact, there are very lengthy prospective studies linking early childhood abuse to various negative outcomes. Probably one of the best known by Bion, published in 2018, was that early childhood abuse was linked both to adulthood dissociation and disorganized attachment style. Other characteristics of adults who have experienced abuse and dissociative functioning as kids are, first, that interpersonal relationships are difficult, experienced with ambivalence, avoidance and distancing, and sometimes dismissive attitudes. Emotion regulation skills are compromised, and reliance on others for co-regulation, such as social support, is impaired. And I think very sadly and problematically is when a person or a client is in a dissociated state, by virtue of that state, the comfort of others may be inaccessible. So it's sort of just when a person needs soothing, comforting to reintegrate and reorganize, it is the moment at which they are least able to be aware of it and access it. So I wanted just to mention important clinical considerations in treating, individuals with dissociation. Hold on a second. First, of course, is to assess the severity and the type of dissociation. And I think there are two wonderful and very short scales that can do this. The dissociative symptom scale by Eve Carlson and colleagues, there's an 8 and a 20-item version, so very easy to deliver and gives you those 4 or 5 different dimensions of dissociation. And the TSI dissociative subscale that was developed by John Briere, it is 10 items, also short, and its benefit is that it identifies a cutoff, which indicates risk for dissociative disorder. The other things that I have found helpful as a clinician is to agree ahead of time that the client will relay when dissociation is occurring, and also to identify preferred interventions to resolve the dissociation. And this links to what I said before, which is that when people are in a dissociative state, it is not the moment to begin planning how to manage it, because the person is already in distress and already in a condition cognitively, emotionally, and relationally difficult to be able to work with a therapist. So my general goal is to identify triggers and intervene rapidly and resolve the dissociation before it has a chance really to launch. And I think also therapists can become familiar with clients' indicators of dissociation. If you work with someone, you become familiar with behavioral manifestations of their particular dissociation. So, for example, I might note their speech slows down, their eyes move back and forth, or there's hand gestures such as rubbing or other self-soothing behaviors. All right. So one might ask, almost rhetorically, why treat dissociation? And it's because it's very impairing. It is generally very distressing to the people who experience it. It is associated with suicidal ideation, self-injury, and suicide attempts, and also provides those people who have high dissociation tend to receive less benefit in a variety of therapies, but particularly those that are purely exposure therapies. Okay, so what have been treatment recommendations for dissociation? It is interesting to note that there are no evidence-based guidelines nor evidence-based treatments for dissociation per se or dissociative disorders. And I think that's probably because it's very complex and it looks very different amongst different people and depending on the kind of disorder they have. So there are these broad recommendations that have been made. And the first is to integrate interventions to reduce dissociation, particularly using emotion regulation strategies, and usually in a phase-based manner, with the emotion regulation strategies coming first, followed by the trauma-focused work. I do think there is becoming more interest and flexibility and openness to thinking about alternative approaches, which might be to include interventions targeting dissociation in an integrated and flexible manner with trauma-focused strategies as needed. I want to share with you now, sort of shifting to the empirical literature on studies that have actually dedicated themselves to the evaluation of the impact of treatment on dissociation. So there are at least 2 studies that show that multi-component or more complex treatments are superior for those with high levels of dissociation. Sorry, I'm having trouble. Moving my screen. All right, so the first, not surprisingly, treatment used to evaluate dissociation and create shifts in dissociation is stair narrative therapy that I and my colleagues have developed. It is an 18-session treatment where the first 5 sessions really focus on emotion regulation. The second 5 enhance relational and social capacities, particularly around co-regulation and engagement in positive ways with others. We then shift over to the narrative work, which includes components of both exposure to the traumatic memory and cognitive reappraisal or meaning making around it. The emotion regulation strategies that are used include body-based intervention, which are flexibly selected depending on the preferences of the client, and they include focused breathing, self-soothing, and an exercise plan. There are cognitive interventions such as emotion surfing and positive self-appraisals, and there are behavioral interventions including behavioral activation, positive activities, and timeout, moving out of the distressing situation. The interpersonal interventions really come from an attachment frame of mind, where the first task is really to identify and normalize trauma-generated interpersonal schemas. And we really try and pull for contingencies on attachment, such as beliefs like, if I express my feelings, I will be rejected, right? One can imagine that coming from a person who's experienced emotional or physical abuse early in life. And then validating those beliefs as based in traumagenic experiences, but also inviting the person to formulate and test alternatives, so, alternative attachment frames, essentially. If I express my feelings, my partner will be interested and appreciative. Or if I ask for help, you, therapist, will respond. So here are some data evaluating stair narrative therapy and its impact on dissociation. This is a study of 104 women with PTSD related to childhood abuse. And each of the graphs that you see represent people who had a particular level of dissociation using the TSI dissociation scale. And what you'll see if you track from the first to the last graph is that at low levels of dissociation, stair narrative therapy, which is in the red, doesn't really perform any better than its 2 comparators, which was just stair alone, skills training, followed by continued supportive counseling, or the narrative therapy alone, which is a kind of exposure therapy. But as baseline dissociation increases, particularly by the time that one gets to a level 2 dissociation, you can see the advantages of STAIR plus narrative therapy in the reduction of dissociation, and you move to level 3 and level 4, such that people with level 2 or more dissociation receive significantly greater benefits or reduction in dissociation as seen by that red line compared to the blue line, which is skills training only, or the green line, which is exposure only. And I should mention that in the TSI dissociation subscale, a score of 1.8 is the cutoff score for people likely to have or at risk for a dissociative disorder. So this treatment looks very good in working with and producing significant reductions in dissociation. Another aspect of the treatment was looking at its reduction in PTSD. Now, interestingly, there really were no differences in reductions in PTSD by level of dissociation. Everyone, regardless of their dissociation status, did better in STAIR narrative therapy. So, for example, you'll see that for the sample as a whole, 61% of people who had STAIR narrative therapy resolved their PTSD diagnosis compared to STAIR without exposure, 47%, and then compared to the narrative therapy without STAIR, 33%. However, at the end of treatment, among those ending with moderate dissociation, that is a score of 2 or less, and I should say there was no one with by the end of treatment that was any higher. Everyone had resolved their high levels of dissociation, but those with moderate dissociation differed depending on the kind of treatment that they've gotten. That people with STAIR narrative therapy in the red continue to show improvement over time in the follow-up phase. Those that received STAIR stayed the same. They maintained their gains. And those who had basically exposure without any skills training actually got worse. You'll see in the green line at 3 and 6 months, there's been a relapse into PTSD. And we were curious about trying to figure out what this meant. And we're thinking that skills training helps people after they completed treatment to modulate their feeling states, to engage in social support, so that they routinize these positive behaviors, and it actually would prevent increases in PTSD or dissociation at times of stress. So their confidence would grow, their symptoms would decrease. And for people who experienced the narrative therapy alone, they were able to resolve their past traumas and symptoms related to those past traumas, but yet we think probably didn't have the skills to manage new stressors, not even traumatic stressors, general stressors, so that upon exposure to them, there was an exacerbation or relapse into symptoms. So the goal, I think, in STAIR narrative therapy is both to resolve the past and enhance capacity to function in the present and future. Another study that was done around the same time was conducted by Patty Rezick using cognitive processing therapy, and she looked at the role of dissociation on PTSD outcome. And what you see here are an assessment of people with low dissociation, I think using the same measure, the TSI dissociation subscale, low, and just breaking it up into 2 parts, low dissociation and high dissociation. And this study evaluated 3 different kinds of treatments. One is traditional CPT, which has an exposure component and a cognitive appraisal component. The second is WA, which is the written assessments or assignments. That's the straight line, and that eliminated the exposure, the cognitive work, and just was basically purely an exposure therapy. And then what was called at the time CPT-C is the dotted line, which is just the cognitive appraisal. And what was interesting is that people with low dissociation did best, or actually got better faster, although in the end pretty much everybody was the same. So that low dissociation, or people without dissociation, seemed to do well without any kind of exposure component. And in fact, cognitive processing therapy now is just called cognitive processing therapy, even though it no longer includes the exposure component. It's at this point now pretty much purely a cognitive therapy. However, interestingly, individuals who fell into the high dissociation group did best with traditional cognitive processing therapy, which included both exposure and cognitive appraisal. And so this treatment is more complex, has more components, and was similar length. So it is interesting that maybe dissociation has several dimensions to it that can be or maybe need to be addressed in different ways. All right. As a result of these studies, or I should say these studies contributed to, amongst many other things, the decision in DSM-5 to include a dissociative subtype. And in particular, that subtype is described with a couple of symptoms called derealization and depersonalization. And probably at this point, the only study that I know of that's evaluated the cognitive, the value of the subtype is in kind of a retrospective assessment of prolonged exposure, pretty much a pure exposure therapy, looking at outcomes amongst people who had high PTSD, in the dotted line, high PTSD and dissociation in the solid line, and moderate dissociation, which I think is a colored line. And the results indicate overall that people with high PTSD and dissociation had a flatter slope, which means that they did not improve as much over time. And in fact, those with high dissociation received less benefits by approximately 10 points. This ultimately did not turn out to be significant. And when you look at changes in terms of PTSD resolution at post-treatment, those with the dissociative subtypes and those high in PTSD showed a relatively low resolution, 18% and 19%, while those with moderate PTSD and resolved a bit more, around 26%. So overall, one conclusion was that there wasn't, that dissociation did reduce benefits in this exposure therapy. However, another conclusion can be that the exposure therapy had pretty limited impact overall on PTSD resolution, right? So here we're seeing resolution of about 20%, 20 to 25%, whereas say in the stare narrative therapy, it was more around 60%. So maybe both people with high PTSD and dissociation should be provided with amplified treatments. All right, other therapies one might want to consider is EMDR, a lovely treatment I think of it, and I know Francine Shapiro viewed it as a phase-based treatment. It essentially has 6 phases. And in it, there is an incorporation of grounding or going to a safe spot, and done in a flexible way as needed as people review and process their trauma. Another therapy that might be interesting is trauma-focused CBT. It is has a lot of adaptations to it. It can include, for example, movement. There are behavioral experiments which are really lovely that increase sense of safety and mastery. And there's social engagement in ideas around reclaiming one's life. I don't know if there have been any systematic investigations around those with and without dissociation and the relative impact of these treatments for these 2 groups of people. All right. One of the things I wanted to bring up here, as John sort of intimated, is the role of dissociation in ICD-11's PTSD and complex PTSD diagnoses. As you may know, ICD, as distinct from DSM, went another way and developed 2 different diagnoses to explain typical consequences of traumatic exposure. PTSD is made up of the classic triad of re-experiencing, avoidance, and sense of threat, along with functional impairment, while complex PTSD is typically associated with multiple or chronic trauma and also childhood trauma, and its symptom set includes re-experiencing avoidance and sense of threat, but as well additional 3 triad, which are called disturbances in self-organization, and include affect dysregulation, which is made up of both hyperreactivity, such as having difficulty calming down, and hyporeactivity, emotional numbing. Negative self-concept, beliefs about self that I am worthless, I am a failure, and feelings of shame and guilt, and disturbed relationships, very much like those described in people with childhood abuse and dissociation, namely typically avoidant and dismissive. Since the time that the diagnoses have been introduced, we probably have at least 30 studies now in both clinical, community, and epidemiological samples indicating that these 2 distinct profiles emerge. As you see here, this is a study conducted in the UK in a mental health outpatient clinic where the top line describes complex PTSD with patients endorsing re-experiencing avoidance and threat, as well as affect dysregulation, negative self-concept, and disturbed relationships. In contrast, there were about 40% or so in this study of people who endorsed the PTSD symptoms, but not the disturbances in self-organization. So the question is, how do these 2 disorders relate to dissociation? And there are a couple ways it does. Dissociation differentiates ICD-11 PTSD from complex PTSD. Individuals meeting criteria for ICD-10 PTSD have substantially higher levels of dissociation than those with PTSD. And in fact, particular kinds of data analyses have shown that dissociation is associated particularly with 3 clusters. Not surprisingly, re-experiencing in the here and now, the affect dysregulation symptoms, and they are both hypoactivation and hyperactivation, and relationship disturbances. Similarly, childhood trauma and attachment differentiate PTSD and complex PTSD. In a study I conducted in the United States of a national epidemiological sample, cumulative childhood trauma increased risk for complex PTSD compared to PTSD up to 20-fold. so that by the time a person reported 4 or more childhood trauma, 4 different types of childhood trauma, their risk for complex PTSD was 20 times more than for PTSD. And CPTSD is also associated with attachment styles of anxious attachment as well as avoidant attachment, just as we might have predicted. The question is now, if we have a disorder of complex PTSD and we have this multidimensional construct of dissociation, how are they truly related to each other? And I think there is overlap, but that they are distinct constructs. So first of all, there is definite overlap in the sense that there are 2 symptoms in CPTSD that are dissociative. One, of course, is very classic, re-experiencing, which is a disconnection from memory, time, body, sense of self, and others. And the second is affect dysregulation, particularly hypoactivation, which is represented in complex PTSD, particularly by emotional numbing. In earlier analyses of organizing the hypoactive types of symptoms, emotional numbing and derealization and depersonalization were highly correlated with each other. But ultimately, we were asked by World Health Organization to be limited in symptoms and to select the symptoms that we thought were most representative of the construct and also most likely to be invariant across different cultures and countries. And ultimately, we found that to be emotional numbing. So our view is that emotional numbing represents dissociation of a kind. It is associated with derealization and depersonalization. However, it is more commonly reported. Our sense in talking with many experts is that it's possibly more easily translatable into different cultures and languages, and possibly the experience may be more invariant than derealization or depersonalization. I think the relationship difficulties we've actually shown are related to dissociation, and I think they're dynamically related to dissociative processes. So, for example, trauma-related interpersonal templates, as described earlier, that avoidant, disorganized type of attachment generate dissociation. And then as a person gets older or through time, dissociation, which is essentially a disconnection emotionally and cognitively, actually reduces relational engagement. And this can go on, dynamically and reciprocally, bidirectionally across time. So what in the end are we to do? And I think we really don't know yet. And I just wanted to share with you my thoughts about the relationship between CPTSD and dissociation. And these are just considerations that I think probably CPTSD symptom profile is likely to be more common than the dissociative disorders. It may also be more reliable in its presentation, namely that the same symptom profile presents across different situations, different people, and different cultures. And I think because of this, the reliability of this profile will help us translate into established and effective treatment protocols. However, I do think that treatment elements between dissociation and CPTSD are likely to be shared, particularly in regards to emotion regulation and relational capacities. I also think that possibly the treatment structure will be similar, that one might want to integrate several interventions, both trauma-focused and emotion regulation kinds, either in a phase-based or in a flexible way as needed. So this is where we're at in terms of the relationship between CPTSD and dissociation. I think possibly from a research perspective, it would be good to do a systematic assessment of the relationship between dissociation and CPTSD. We really don't know. There are lots of different possible relationships. One is that dissociation is a mediator between trauma and CPTSD. The second is that dissociation moderates the relationship between trauma and CPTSD. That dissociation provides CPTSD when high and maybe other disorders when not. It could be that dissociation is a comorbid outcome from trauma, that they both come from the same place and they are distinct and travel along side by side. Another possibility is that the two should be integrated in some way. And lastly, it's possible that dissociative experiencing could be a subtype of CPTSD, just as been presented in the DSM disorder of PTSD. And I want to thank Connie Dallenberg and Eve Carlson for systematically reviewing what the options were. And we'll probably be proceeding in our research on trying to figure this out. So that's all that I have to say, and I'm happy to discuss and take questions. I'm going to stop sharing my screen. Yeah.
Yeah, no, sure. Brilliant. Thanks ever so much, Marilyn. That's really clear and a very, very interesting presentation. So the floor is open for any questions. I mean, you can type them into the chat box to the side, or I guess people can shout out actually, or put up their hands if they want to, as I think everybody's got control of their microphone. So any questions or comments for Marilyn? Thank you. So Catherine is asking from Swansea Bay, can you describe the difference between dissociation as a mediator and as a moderator between trauma and CPTSD?
Well, I understand the mediator much more easily, that trauma occurs first, followed by dissociation, which then influences and describes complex PTSD. Moderator would be that depending on level of dissociation, we would get a certain characterization of complex PTSD that might differ, and different sets of symptoms.
Sense. Catherine, are there any other thoughts you've got on that? Or thank you. Is Catherine's typed in, so thank you for that, Catherine. Any other questions or comments or thoughts? Clearly a very important area for us all. So Gillian from Swansea Bay, could dissociation be seen as a way of someone trying to meet their needs? Interesting.
Yeah, yeah. I think. Well, I mean, I think absolutely. It's definitely the theoretical frame for dissociation in early life, right? That the imperative of a child is to connect. And when that caregiver is abusive, the child still needs to connect, but manage that threat in some way. And so they do that by removing part of themselves. Some people say they remove part of themselves to save that part of self for health. And that's been described as the genesis of dissociative identity disorder, right? And the development of multiple selves. But there are ways in which reduction in affective reactions, reductions in awareness of what's going on, that this person is actually very threatening, and forgetting that the person that you're connected to now was also the person who was harmful and hurtful to one's physical integrity. So yeah, pretty much all of the descriptions of dissociation in inescapable circumstances, and particularly in the caretaking or attachment interpersonal realm, is for the purposes of enhancing survival, which means enhancing engagement with the object of threat. Yeah.
Gareth from Powys asks, are sensory integration techniques used to treat DID, dissociative identity disorder?
I can't answer that question because I don't know what they are. It sounds right on. I mean, I think that one of the ways that all of our therapies can be improved is by the introduction of some body-based work. You know, we've done so well with the cognitive realm, thinking differently, even feeling differently, but we haven't really integrated the experience of the body and feeling healthfully embodied after trauma. We've kind of ignored it.
And I don't know if you can see the chat, Marilyn, but Jill thanks you for your answer with a smiley face, which is nice. George from Haldar asks, what does research say about chair work and dissociation?
That's interesting. I don't know of anything that is said about it. However, I can imagine certainly it possibly, you know, shifting one's attachment organization, right? The capacity to put yourself in somebody else's shoes and feel what it's like. If I understand the technique, yeah, and might reorganize the interpersonal dimensions of dissociation, where people stop being such threatening objects. You know, I think that's really one of the most negative and saddest consequences of dissociation because of trauma and dissociation, because basically all through our lives we use co-regulation to help us do better under conditions of threat. Certainly we need to, as children, right, internalize the emotion regulation given by the caregiver, but even in times of threats as adults, social support, you know, is the transformation of that co-regulation experience. You know, when people hug each other, people send dishes to each other, right, soothing and food. You know, this taking care is known to actually create better, you know, emotional state. Those are community-based emotion regulation strategies. You know, and people believe that we build from the initial dyad in understanding the importance of co-regulation and grow it to a community level as adults, as part of a community of people.
Thanks, Marilyn. Lisa from Haldar, well, comment really, speaking to parts of self would be helpful to integrate aspects of the self that have been disowned.
Yeah. I mean, I have to say I'm not an expert at all in dissociative identity disorders, but I think the idea of having compassion for these other selves, because they've done such a job, you know, over time, to help continue functioning, that I imagine respecting them, having compassion for them, is part of the process of being integrated. I suppose even when they're no longer needed anymore, because that's the point ultimately, you know, that they've done their job and hopefully the individual can pull themselves together into one integrated sense of self.
And Jane from Cardiff asks, I would be interested in your thoughts on the effectiveness of EMDR with dissociation, particularly in view of the differential impact of skills-based therapies for PTSD with and without dissociation.
I think that EMDR would do just as well as stair narrative therapy, because I think they're in many ways very similar. They're very phase-based and kind of move back and forth between being trauma-focused and, well, in EMDR, developing emotion regulation skills to manage the trauma, but also I'm imagining also used in daily life. What I like about EMDR is that flexibility, which is more flexible than stair narrative therapy. Stair narrative therapy has been very sequential and
I'm always like, does I have a question? I will know ask it. But you know, when
Someone might have
looking
a
at
microphone on, actually. I don't know if somebody, yeah, thank you.
so what I appreciate about EMDR better than stair narrative therapy is its kind of patient-centered, flexible use of these different techniques during the course of therapy. You know, the question of whether you really need to sequence things and the possible advantages of sequencing is really unknown. You know, I'm pretty convinced that combination of these things is better than just, you know, exposure alone or skills alone. Pretty confident. But how to integrate them, I think, is a very interesting question and remains for research. I think the other aspect of EMDR that I think is good for dissociation, probably good for everybody, is that it identifies positive experiences. And I believe positive memories as well. And I think, you know, to be a full person and to be able to tolerate the fullness of life, identifying, you know, both that the fact that there's both positive and negative events, positive and negative experiences is important.
Any other thoughts or questions? Jane, thanks you. That's great. Oh, one thing that I mean, I think comes out very strongly is sort of that you've mentioned it a few times, the body side of things and the somatic side of things, Marilyn. I was just wondering about your thoughts with complex post-traumatic stress disorder, which has clearly got some elements of dissociation in. One sort of omission, if you like, in some people's minds would be somatic symptoms. And I was just wondering if you would comment on, you know, somatic symptoms and their presence and how common they are in people who present with a, you know, complex post-traumatic stress disorder.
Yeah, I think that's a good question to which I don't really have an evidence, you know, empirically based answer. My thought is that, you know, the soma and the body is very important and it is an integral part of recovery, but that somatic symptoms likely differ culturally, which was one reason, you know, in WHO that we're trying to identify super core symptoms. And I have a sense that somatic symptoms will differ by culture. And I also have the sense that they may be relatively rare, like derealization and depersonalization, which are very impairing, but insufficiently frequent to be part of the diagnosis, but might be related to other symptoms like emotional numbing. I think it's interesting.
Yeah. No, thank you.
In the study that I mentioned to you, the 104 women who had PTSD related to childhood abuse, we actually did an assessment of somatic symptoms and conversion symptoms, essentially. And we found very, very low positive responses to that, like under 1%, under 1%. So maybe we're a culture that has lost its way and, you know, doesn't think about bodies too much, or maybe we are sufficiently emotionally expressive that it's not contained in the body anymore. I don't know. But that doesn't say we shouldn't think about body and recovery. And maybe we are just, I mean, we certainly know that people who have experienced chronic trauma have multiple health disorders, you know, real health disorders. So I would say ultimately we will find that trauma that with complex PTSD, we're going to find many more physical health disorders and diagnoses. You know, when you think about the ACEs, there's a dose response relationship between number of traumas and cardiovascular problems, gastrointestinal problems predominantly, maybe some gynecological problems too, and early death. So I'm thinking that they will be comorbid, but distinct.
Yeah, no, thank you. And so Eileen from Cardiff says, personally speaking, EMDR has very good results with somatic symptoms. At times we only concentrate on the body with good results. And then Sadia from Cardiff as well, when talking about parts of the individual, is this the same as working with parts within the internal family systems? Interesting.
I have forgotten a lot about internal family systems. So I'm not sure. I mean, they're both efforts after integration, right? One is integration of self. And yeah, I can't answer that. I don't know enough. But I'm happy to hear your thoughts.
Sadia, have you got any thoughts on that? I mean, if anybody wants to sort of talk to this, then please do, because you can. In the meantime, Siobhan, in recent NET training, narrative exposure therapy training, there was discussion around the defense cascade theory and dissociation. Do you have any views regarding this, please?
Can you explain what you mean by the defense cascade?
I don't know, Siobhan, if you're there with a microphone, you might want to explain.
Hi, I'm on the spot now. So my understanding of this theory, which is from Schauer and Elbert, 2010, it's their sort of theory about dissociation following traumatic stress, sort of etiology and treatment, and it's a sort of bell-shaped curve. So on the y-axis, you've got the defense reaction, which is increasing, and on the y-axis, you've got the cascade progression and course of action. So they sort of start with the freeze response, which is, the attentive immobility and orienting response. And then on the upward tick, you've got fight or flight, which is the uproar. They describe as the uproar type 1 sympathetic activation. And then at the top of the bell-shaped curve, it's tonic immobility or unresponsive immobility, which they describe as fright. And then as you come down from the curve, it's the flag, which is flaccid immobility, which is the shutdown, which is the parasympathetic activation kicking in. And then at the bottom of the bell-shaped curve, it's faint. So it's like a 6-stage process. It was beautifully described, I have to be honest, in the recent training, but I just wondered if it was something that you were familiar with or had a sort of view on that. Yeah,
no, I'm really not. I mean, I know NET. I've taken a workshop myself. It's a really beautiful therapy for lots of reasons. But I'm not really sure how the cascade as described kind of overlays or translates directly into their treatment work. Because NET is pretty much exposure based. You know, it is the telling of stories of trauma. I mean, I would agree with the cascade, sensible, but I'm not sure how NET in particular addresses this cascade any differently than many other therapies. So I would ask them.
Thank you.
But yeah, I agree with you that it's nice to hear it so well described. Yeah. Okay.
Sorry, I was on mute. Devendra, you have your hand up.
Yeah, thank you. Marilyn, most of my patients in a low secure hospital, they have frequent somatic concerns. So, they are not reassured by a doctor. They are not reassured by the GP. And frequently we have to take them to the general hospital and they feel reassured by the hospital visit. And your research with 144 patients, says that somatic complaints are very less than 1%. It So your thoughts on that? It doesn't correlate with the observational experience of that I see with my patients.
Well, I think there may be, differences in the cultures and values of patients, and what might be appropriate ways of expressing the impact of trauma. So I think it's kind of consistent with my point before that we see a lot of variation around somatic symptoms, both I think in terms of frequency and type.
Yeah, thank you.
Thanks, Devender. So Eileen, who clearly knows more about this than I do, says that her understanding is that internal family systems is similar to ego state work. Correct me if I'm wrong. So, please do write if you think that Eileen's wrong. I suspect you're probably right, Eileen. But yeah, one that we can all go away and read a bit more. Deborah says, regards somatic effects, I've been thinking of a recent webinar that talked of epigenetics and the physiological changes as a result of adverse childhood experiences. I do not have the experience of learning to expand. However, I have wondered if there may be a connection there.
Yeah, I think that's very interesting, that trauma impacts the very genetic construction of ourselves, and that it's passed down from one generation to another.
Yeah.
Yes.
I totally agree.
I think we'll just learn so much more about it. And, I think my immediate reaction is minimally, from a policy perspective, how important the experience of trauma is, to us as a society and to us, in terms of public health and changes. Yeah.
No, totally, and that's a nice segue, actually, Marilyn, for me to mention the trauma-informed Wales framework that's just been launched and published in Wales, which is trying to look at a societal response to become more trauma-informed across society, and that's something we're working on in Wales at the moment. Many of the audience, I'm sure, are involved and will be involved in that moving forward. Yeah, and Eileen points out there's some interesting work on EMDR training on intergenerational trauma. There's some really fascinating papers in the literature if people do want to read about intergenerational trauma. I was reading some stuff recently around Holocaust survivors, which is fascinating on the intergenerational trauma stuff. And David says, given the overlap between borderline personality disorder and complex PTSD, why do patients with a significant trauma history receive borderline personality disorder diagnosis?
Well, that's a great question. And, I think it's two answers. One is that I think it's very difficult for us to know the prevalence of comorbidity between the two, because I think it'll vary depending on where you select your sample, right? So in, epidemiological samples, I think we're going to see pretty low comorbidity. In outpatient settings, maybe, some moderate level comorbidity, by which I would mean like 20% or so. And then we've definitely heard from people who are working in high intensity inpatient settings where the comorbidity is extremely high, like over 50%. And I think that might speak to this idea that the two are related to each other on a continuum of severity, where borderline personality disorder is a more severe form of mental health problem than complex PTSD. However, at the moment, there are ways in which we can distinguish between the two, diagnostically speaking. They are distinct in very important ways, by which I mean they have different treatment implications. So, for example, with complex PTSD, we have disturbances in identity. However, in the case of complex PTSD, sense of self is stable. Person feels very worthless, feels like a failure, feels full of shame, but they always know who they are and they're one person. People with borderline personality are unstable in their sense of self. Their values about them shift, their directions for life shift. And so you can imagine that treating people with a stable sense of self versus unstable sense of self is different, with the latter being more challenging. And there's a similar issue with interpersonal dynamics, right? People with complex PTSD tend to be withdrawn, avoidant, maybe a little disorganized, maybe dismissive, and more likely to detach, where with borderline personality, by definition, relationships are volatile, there's connection and disconnection. And so you see differences in how they relate to people, and also what the interventions you might need for interpersonal functioning. And you also, as a clinician, feel very different in the room with a person who has borderline personality disorder. They love you, they hate you, they love you, they hate you, where a person with complex PTSD might be, respectfully disengaged, something like that. So experience is very different. And so just taking those two differences, which I think are the key differences, one is that you would assume with borderline personality disorder, you'd have a much longer course of treatment. Yeah. Because I think developing a sense of integrated self is a high order task. And also developing a sense of desire to sustain relationships, in a constant way, also may be more challenging. So, for example, in complex PTSD, the intervention in interpersonal work is to say, what do you want in a relationship? And basically reduce avoidance. It used to be an anxiety disorder. So you might say, okay, you want to engage with people. So you might develop a hierarchy of continued exposure to social engagement and relationships. In DBT, for example, with borderline personality disorder, what you're accenting is consistency and a constancy in relationship, and moving values and emotions and behaviors to be consistent with that ultimate goal. Do you want to maintain this relationship? Well, then running away or, having sex with another partner is not consistent with that goal. So sort of managing the impulsivity and the volatility that's inherent to borderline personality disorder towards purposes of, stability. I think it's quite a job. And also, I think there's argument about this, but in my own research in clinic, borderline personality disorder, about 50% of individuals had made a suicide attempt over the past year. With complex PTSD, about 15%. So much lower, where in borderline personality disorder, a key goal, an immediate goal in treatment is resolving self-injurious, and life-impairing habits, where in complex PTSD, it's one of a set of symptoms, but I actually think if you work on the emotion regulation, you'll probably resolve the suicidality. And it's not to say complex PTSD doesn't have higher rates of suicidal behaviors. I mean, 15% is 5 times as high as the national average in the United States, which is around 3%, right? So it's higher and salient, but in BPD, it's core. And I think it's the central disturbance and the immediate goal of treatment, whereas in complex PTSD, not so much. And I think a last difference is feelings of abandonment. My experience with termination with these two groups is very different, where in complex PTSD, there's really not people tend to be accepting of relatively short-term treatments, 3 months, 6 months. My experience with borderline personality disorder is that you really need to actually include in the treatment an aspect of managing feelings of abandonment so that you can end the treatment with the gains intact. So I think the central goals of the treatment, duration of the treatment, and the way the treatment ends are different.
No, thank you, Marilyn. I think that's a really helpful explanation and a really helpful way to end this afternoon's webinar as well. So thank you so much for that. For those of you who've been keeping an eye on the chat, there's been an interesting chat around internal family systems that I've been learning from as well. So fantastic. Thank you ever so much to everyone for your contributions today. And of course, a special thanks and massive thanks to Marilyn for taking the time early in the morning in the west coast of America to join us today. So thank you so much, Marilyn, and thank you everybody else very much. And we'll be in contact, to give you access to some of the talks after today. And you can probably see now, Marilyn, there's a lot of appreciation going on in the chat column. So we'll say goodbye and take care, everyone. Thank you.
All right. Thank you very much, everyone. I'm happy to be here. Thanks for the invitation, John.
No.
Bye-bye now.
Thanks so much. Bye.
Bye.
Hi guys, I'm just removing everybody from the meeting.
Really nice comments coming through.
Lovely, aren't they?
I thought that was fascinating, actually. I mean, I'm sorry I couldn't come along to this morning. Did this morning's go well?
Really good.
I
Brilliant.
think it was fine.
Brilliant. Good.
Yeah.
Good. No, I learned a lot from this afternoon, I have to say, on a personal level.
John, and David, just nearly removed you too.
Oh no, that was great, wasn't it? I think the both of them, they were really good, really interesting.
Oh, good. Glad you enjoyed it, David. And so there's some good art therapy mentions in there as well.
Yes.
Yeah.
Excellent. Yeah, that's what we like to hear.
Yeah, quite. Yeah. Okay. I'm really pleased that Mel came up with did a presentation for us. That was great, wasn't it?
Yeah, and I found that sort of, again, that interview with Karen, wasn't it, was fascinating. I thought that was